I'm David Goff. I'm privileged to be Dean and Professor of Epidemiology here at the Colorado School of Public Health. And I want to welcome you to the 2013 Public Health Exchange, which includes a couple of special events, including celebration of the 5th year anniversary of the Colorado School of Public Health. This is a great time for us to look back on the accomplishments over the past 5 years and really decades prior to that, but also to look forward to what's yet to come. And so in that spirit, today we're going to hear a bit about the research mission of the school and research accomplishments from each of the departments. So the way the day is laid out, Tim Byers, who we need to thank for putting this together, asked me to talk a little bit about the research of the school in an overview, and then each department will have some time to highlight some selected research from their groups. Now, this will just be a small taste, and there's much more going on than we'll be able to get through today. In future public health exchanges, we'll have opportunity to look at other things that are going on within the school. Let's see. So again, if you'll help me, let's thank Tim Byers for putting this together. I'm sure Tim would want us to also recognize Nikki Semino and Terry Bookin. Nikki in particular put a lot of effort into organizing this, and so please join me in thanking Nikki. Okay, so I'm going to talk a little bit about the research of the school. First, the mission, to remind you, and for those who may not have seen it recently, the mission of the Colorado School of Public Health is to promote the physical, mental, social, and environmental health of people and communities in the Rocky Mountain region and globally. And we will do this by being a collaborative, multidisciplinary, multi-institutional learning, research, and service environment that will inspire academicians, practitioners, and students of public health to work collaboratively to assure that all people and communities are healthy and their environment sustainable. And certainly research is a major component of that. The research mission of the school has grown substantially over the past 5 years since the establishment of the school. This chart shows in graphic representation the growth in research within the Colorado School of Public Health from fiscal year 07 to fiscal year 12. Showing an increase of about 50% in research funding. And that funding is represented across the departments. We have strong research missions in all 5 departments of the school. This table, I'm an epidemiologist, so I like numbers. This table provided by Tim shows the numbers in dollars of research brought into the school by principal investigators within each of the departments and centers associated with the school. So you'll see on the here on the rows the different departments: biostatistics and informatics, community and behavioral health, environmental and occupational health, epidemiology, and health systems management and policy. And across the top, the columns are represented by the various centers that are associated with the School of Public Health: the Centers for American Indian Alaska Native Health, the Cancer Center, Rocky Mountain Prevention Research Center, the Center for Public Health Practice, the Center for Global Health, and the Mountain and Plains Education Resource Center. And the total research funding is about $26 million in the school. That's direct cost. And the centers contribute substantially to the research mission of the school, as you can see from this slide. Another way of looking at it is in the crosswalk between departments and centers, shown pictorially for those who are more visual learners, is to look how each department is doing and how the centers cross departments or add to the research missions of the departments. And that's what's shown on this slide. One point I want to make that I know Denny Lazat will make when he talks about the Department of Biostatistics and Informatics is that in addition to this way of looking at our research mission, which focuses on the grants brought in by principal investigators based within the school, our faculty are highly collaborative. And so there's a much greater impact on the research mission of the campus than is shown on this slide. For example, the Department of Biostatistics and Informatics collaborates on research valued at over $100 million a year on this campus. Over the past couple of months and really several years, as the school has been going through a strategic planning process, the school has also been identifying its areas of research strength that are being prioritized for strategic planning purposes. And this slide shows the current thinking about those areas. Doesn't mean that this is carved in stone and won't ever change, but this is the current thinking about the areas that we're prioritizing from a strategic planning point of view. 3 areas that have been identified as being historical areas of strength: cancer prevention research, obesity and diabetes, and American Indian Alaska Native health. And 3 what I'll call sort of emerging areas of strength within the school that are being prioritized strategically at present: worker health, maternal and child health, and global health. And I'll say that at least when I was looking at coming here, one of the things that I found particularly attractive, in addition to the broad strength of the school, was the historical strength and focus on diabetes and obesity work. In fact, the way I first learned about the researchers here and what at the time was the Department of Preventive Medicine and Biometrics was the work going on in the San Luis Valley on the San Luis Valley Diabetes Study. That was one of the best studies in the country looking at diabetes and cardiovascular risk in Hispanic populations. That was a focus of my dissertation work, and so I sought out people like Dick Hammond and Marion Rivers and others at meetings several decades ago to learn more about what was going on here. So Tim asked me to also talk a little bit about research that I've been involved in over the past several years and that I'm continuing to keep a hand in, that we started back in North Carolina now about 5 or 6 years ago. And it's a study called the Healthy Living Partnerships to Prevent Diabetes. And this was funded from a grant from the National Institutes for Diabetes and Digestive and Kidney Diseases through an initiative that they had to fund studies to test approaches to translate the DPP into the community. So I'll talk a little bit about what we've been doing there over the next few minutes. First, I want to give credit where it's due. Although I was principal investigator of this, the work was largely done by others. That might sound familiar to other people in the room. Jeff Catula, a behavioral scientist; Jorge Calles, an endocrinologist, diabetologist; Mark Esplin, a statistician who I think many of you know; Mike Lawler, an economist; Tim Morgan, another statistician; Carolyn Pedley, a general internist; and Mara Vittlemans,
Welcome to Polycom Conference Recorder Playback.
As well as a very capable staff across Wake Forest University and the School of Medicine. So just a very brief background. I think probably most of you know this. Diabetes is a major problem both in the U.S. and globally. I'm going to focus a little bit more on the U.S. And the prevalence is rising. At present, it's estimated about 26 million people in the United States, or about 8.3% of the population, has diabetes. That's about 19 million people who are diagnosed, and another 7 million people who are undiagnosed but have diabetes. That's a major problem because diabetes causes a lot of medical complications for the people who have it. As shown on this slide, things like heart disease, heart attack, stroke, heart failure, blindness. Diabetes is a leading cause of acquired blindness in the U.S. Kidney disease, including dialysis, nerve problems, neuropathies, amputations. Diabetes is the leading cause of non-traumatic amputation in the U.S., and gum infections and tooth loss. So a lot of oral health challenges related to diabetes as well. And that's given rise to a focus on how to prevent diabetes and how to manage the complications, either through treating diabetes or preventing it, and led to the identification of a condition called prediabetes. Prediabetes is a high-risk condition for diabetes. At one point it was kind of called borderline diabetes or a touch of sugar. And it's a high-risk condition. About 10% of people who have prediabetes will develop diabetes each year, according to data from the DPP and other sources. And it's defined, as shown here, based on a variety of different tests: fasting blood glucose between 100 and 125 milligrams per deciliter, or a 2-hour glucose from an oral glucose tolerance test between 140 and 199, or an A1C measure of glycosylated hemoglobin between 5.7 and 6.4%. Based on that definition, Over a third of U.S. adults ages 20 and older have prediabetes, which, when you think about it, is a pretty remarkable number. That represents 79 million people in the United States and many, many more worldwide. This is a major problem growing, and at some point we could talk about the global implications, but not today. Oof. Okay, great. So this slide shows in one slide a quick look at the increasing prevalence of obesity and diabetes in the U.S. over the past couple decades. And you can pick out your favorite state, which is bound to be Colorado, and see that that Colorado had a prevalence of diabetes of less than 4.5% in 1994 and is now in the 6 to 7.5% prevalence range in 2010. More impressively, you can see the entire country becoming higher and higher prevalence of diabetes. Some of this may have to do with better diagnosis, better detection, because this is based on the behavioral risk factor surveillance system, which is self-reported diabetes, but some of this is also reflects real increase in prevalence of diabetes. So what's led to that epidemic? I'm not going to go through all the epidemiology to support this, just going to say basically overweight and obesity, which is related to physical inactivity and poor eating habits and other things that lead to overweight and obesity. Because I want to get into diabetes prevention rather than etiology of diabetes. Current research from efficacy studies shows that lifestyle changes can lead to the prevention or at least delay of the onset of diabetes. And the current recommendations are physical activity at least 30 minutes a day, at least 5 days a week of at least moderately vigorous activity like brisk walking or something of that order. And then nutrition being a relatively low-calorie, low-fat diet that helps with weight reduction. And you combine the physical activity and the healthy diet to get weight loss for people who are at high risk for developing diabetes. Now, this has been demonstrated most prominently through two major studies, the Finnish Diabetes Prevention Study and the U.S. Diabetes Prevention Program. And a little bit of information about those studies here, both published in the New England Journal of Medicine a little bit over a decade ago. The Finnish Diabetes Prevention Study, about 500 people. The treatment condition was individualized behavioral counseling. Follow-up was 3.2 years. They had about 4 kilograms of weight loss and about a 5 milligram per deciliter reduction in average glucose, net difference between the groups. The DPP, published about a year later here in the U.S., tested several different treatment conditions, including lifestyle intervention that was primarily individualized counseling, a drug treatment arm with metformin. There was actually another arm stopped early with the drug triglyceridone. The comparison condition, of course, for the metformin arm was placebo. Follow-up was about 3 years, and again, similar results, about 4.5 kilograms of weight loss and a 4 milligram per deciliter net difference in glucose at about 2 years. So in the Finnish Diabetes Prevention Study, the lifestyle intervention resulted in about a 58% reduction in the development of diabetes. And in one of the remarkable coincidences in the biomedical literature, when the DPP was published, there was also a 58% reduction in the development of diabetes with the lifestyle intervention. So this must be true if you get the exact same answer twice, 58% reduction, something like that. So, and more powerful than the metformin drug intervention, which had about a 31% reduction in development of diabetes. So what we knew at that point was that physical inactivity, poor diet, and obesity increased the risk of diabetes, that interventions to reduce adiposity and increase physical activity and dietary changes reduced risk of diabetes, but there were concerns about translation of this kind of intervention into the community because it was being delivered by highly trained behavioral interventionists in a one-on-one setting in efficacy studies with specialists and highly selected participants. So the NIDDK issued an announcement asking for groups to come together to propose ways to translate the DPP into the community, and our group responded to that and was fortunate to get a grant. And so we implemented the Help Prevent Diabetes study, a randomized trial of a community-based translation of the DPP. And our goal was to test a group-based translation of the behavioral lifestyle intervention with a primary outcome of fasting glucose rather than incidence diabetes. We also translated the delivery mechanism from the way it was delivered in the Finnish study and the U.S. study into a program that could be offered through diabetes education programs at diabetes care centers, working with the RDs that are available, the registered dietitians that are available in these centers, and community health workers, lay people we train to deliver the group-based intervention. Our population goal was to recruit 300 overweight or obese persons with prediabetes, and we evaluated them every 6 months at our General Clinical Research Center. Follow-up was initially funded for 2 years, and we were able to get a renewal of the project to evaluate maintenance intervention in follow-up. But what I'm going to talk about today is the results of the first 2 years of the translational study. The lifestyle weight loss intervention included 3 individual sessions with the registered dietitian in the Diabetes Care Center. These were RDs who were also certified diabetes educators. But the bulk of the intervention were in group sessions led by community health workers that were focused on weight loss, physical activity, and nutrition. The groups were scheduled to meet once per week for 6 months of what we called the intensive phase, and then monthly thereafter for 18 months during the maintenance phase. The comparison condition, we called an enhanced usual care group, where there were 2 sessions with a registered dietitian. This was actually a different RD. This was an RD in the GCRC, so not a certified diabetes educator, but a general registered dietitian focusing on weight loss. And they got monthly newsletters about community resources for weight loss, such as programs at the YMCA, Weight Watchers, and Jenny Craig, and that sort of thing. The weight loss intervention was located in an American Diabetes Association recognized diabetes education program. It was managed by the RDs who were certified diabetes educators who were employees of the diabetes education program. The research team trained them on how to implement the intervention. The intervention was actually delivered by community health workers who were trained by the RDs, not by the research team, and supported by DVDs that included content information from the DPP curriculum. The community health workers themselves were patients with diabetes, who were patients of the diabetes education program in the Diabetes Care Center, who'd gone through diabetes education, made lifestyle change, and were judged by the RDs to have the type of personality and the competency to be group leaders. The RDs were supported by a research team that included the people I talked about before, dietitians, exercise physiologists, behavioral scientists, physicians, and an epidemiologist. And the intervention goals were to get a caloric deficit of about 500 to 1,000 calories per day, increase activity, usually brisk walking, get about 1 or 2 pounds of weight loss per week during the intensive phase, and a goal of 7% weight loss. This is a slide showing the characteristics of our 301 participants. The majority were female, which is common for these kinds of weight loss studies. We were actually quite happy to get a little bit over 40% men because that's unusual in these sorts of studies. And the racial distribution reflected the population of Forsyth County, North Carolina, where we conducted the study. These were mostly middle-aged participants by design, and the average weight was 94 kilos, about 100 in men, about 90 in women, and the BMI average was about 33. The glucose average was very similar to the average baseline glucose in the DPP at 105.5. We had good participation in follow-up. Shown here, about 89% of the usual care participants showed up for the final examination, and 84% of the lifestyle participants showed up for the final examination, showing we had some missing data on things like glucose and weight loss that we had to deal with in our analysis. Intervention adherence was pretty good and comparable to what one sees in the literature, which means it depends on how you look at it, whether you're happy with it or not. We would have liked better adherence, but it's pretty similar to what you typically see. During the intensive phase, about 72% of the expected sessions were attended. If you multiply the number of people times the number of sessions during the maintenance phase, it drops down to about 40%. It's probably a lesson in this. We thought that moving from weekly sessions to monthly sessions would make attendance easier for people. One of the things we heard is that when you change something from weekly to monthly, other things fill up that time slot. And you can think about what those things might be, even, for example, a favorite television show that you might start watching 3 weeks a month. Why are you going to miss it 1 week a month? The churches have this figured out. They have their meetings every week, and they don't go to a maintenance phase of once a month once you've been there 6 months. Oh, well. That's a lesson maybe for the future, but overall, this is fairly comparable to what you see in the literature. The made-up sessions were made up typically by telephone, one-on-one contact with the community health worker, not with a health professional, but with a layperson. And here's what happened to body weight over the 24 months of the study. You can see that both groups lost a little bit of body weight at the beginning. That's not unusual. To 12 months, there was about a 7-kilogram reduction in the weight loss group, about a 5.5 net reduction, and out to 24 months, about a 5 1/3 kilogram loss in the weight loss group, and about 1 kilogram weight loss in the usual care group. And these differences were, of course, highly statistically significant with this sample size. And about a 4-kilogram difference, which if you think back to the slide I showed you on the finished diabetes prevention study in the DPP, very similar to the weight loss difference at 2 years and 3 years in those studies. Percent weight loss looks much the same, about a 4.5% difference in percent weight loss through 24 months. And then fasting glucose, when you see this, you're happy you had a 2-year study and not a 1-year study because, sometimes funny things happen. But these are the data, warts and all. And out to 24 months, there's about a 4 milligram per deciliter net difference between the groups in average glucose, which again is very similar to the results of the finished diabetes prevention study and the DPP with this intervention. So this was the primary outcome of the Help Prevent Diabetes study, and we were very pleased to see that our group-based translation delivered by largely by lay people was highly effective at getting a substantial net reduction in glucose. We also looked at incidence of diabetes. Our study wasn't powered to be able to detect a difference in incidence of diabetes with any assurance, but these are the results of monitoring incidence of diabetes over the 2 years. And at 24 months, 11 individuals in the usual care group had developed diabetes and only 4 in the lifestyle weight loss group. Again, this was not we weren't powered to look at this, but we were gratified to see that at least it was going in the right direction. But the real issue is this less expensive than the DPP? So we've shown it's doable to have a behavioral weight loss intervention managed through an existing healthcare system like a diabetes education program and delivered by lay people. The real question that folks at CDC and NIDDK were very interested in was, could we deliver this in a much less expensive way than the DPP and still retain effectiveness? So Mike Lawler did the economic analysis that was published earlier this year in the American Journal of Preventive Medicine. And in our analysis, the care provided in the study by the usual care group, because they saw a dietitian a couple times, equated to about $142 of value over the 2-year period. Whereas in the lifestyle group, it was $850. So the net difference there is a little bit over $700, as I'll show on the next slide. If you compare that with the published results from DPP, the lifestyle group over the first 2 years, the economic cost there was $2,631. So we were able to deliver the intervention much less expensively, of course, because we did it in a group setting rather than an individual setting. And that's not to in any way criticize the DPP, because that isn't what they were trying to do. They were trying to deliver a state-of-the-art intervention to test whether it works. It was an efficacy study, not a translational effectiveness study. The economic analysis also looked at medical care outside the study, how often our participants sought medical care from their usual care provider or went to the emergency room or were hospitalized. And the estimates of care received outside the study resulted in an estimate of $7,454 over a 2-year period in the usual care group and only $5,177 in our intervention group. This difference perhaps a bit larger than we expected and perhaps a bit larger than you would expect, but nevertheless gratifying. And then non-medical costs, these are issues related to the cost of food, the cost of shoes for walking, many costs that we collected to try to get an idea of the non-medical cost differences that could be imposed by an intervention that tries to change the way people eat and change the way people are active. And the estimate here was that our lifestyle group did spend more money by about $1,000 over that 2-year period. So when you add those all up and you look at it from a health system perspective or a societal perspective, these are the results of that economic analysis. The direct medical costs, the incremental cost was $708 over the 2-year period to implement our translated version of the DPP. For care outside the study, there was a savings of over $2,000, making the total difference in direct medical costs a savings of about $1,500 over a 2-year period. But as I mentioned, there was about an extra $1,000 of costs on the non-medical side. So from a health system perspective, there'd be a potential savings of about $1,500 over a 2-year period. From a societal perspective, a savings of about $600 over a 2-year period. Now, all of this was very gratifying and perhaps a bit more positive than we had expected when we did this, when we designed the study. So what did we see in the study? We saw excellent weight loss, greater than 7% during the first year, about 5% at 2 years, a decrease in waist size that I didn't show you, but of about 5 centimeters. And for the men and women here, you can imagine what that means about clothing, which might be one of the reasons why there was greater cost, non-medical costs for the lifestyle intervention group, going out and buying new trousers and belts and dresses and so forth. There was a meaningful net reduction in glucose comparable to the reductions in the DPP and the Finnish diabetes prevention study. There was a low frequency of adverse effects, which I didn't show you, but a low incidence of diabetes, and a very favorable economic analysis, which is otherwise known as cost saving, all achieved with lay community health workers and community-based systems with a high potential for dissemination through existing diabetes education programs. There are over 3,000 ADA certified diabetes education programs in the United States, and so we think this is a highly disseminatable model. So what do we know about lifestyle management of prediabetes at this point? We know the obesity epidemic has really fueled the epidemic of diabetes and the metabolic syndrome and prediabetes, and evidence I didn't show you today because of time is that this is really threatening the progress we've made over the past 50 years in the prevention of heart disease and stroke. So it's a really major public health problem for us. Diabetes is preventable or at least delayable through lifestyle change to promote weight loss. Both professional and community health worker approaches are effective. And what we really need at this point is the establishment, I think, of diabetes prevention training centers around the country to disseminate this strategy and other strategies for implementation of the diabetes prevention program intervention that was really documented to be effective, in part through work done here through the diabetes prevention program site here. And of course, what we really need is to change the world and change the physical activity and food environments so that we can prevent diabetes through environmental change. But that's yet again a topic for another day. And at this point, I'll stop and maybe take a few questions or comments from anybody in the audience. Please stand up if you have a question. Yes.
Hi, I'd like to ask a bullet point. I work in public health. How is the university preparing students to be ready to work on policy change?
Well, that's a great question, and I would say that within our MPH programs, we are teaching about social determinants of health, and we are teaching about policy and environmental approaches to improving health. That's something that's very important to us. We're also, through our practicum program, sending students out into the community to work with public health agencies and community-based organizations to learn on the ground what's going on in those places to do exactly what you're talking about. So there may be ways we can do a better job, and we'd look forward to hearing from you if you have ideas about how we can do a better job.
Wonderful findings, and what, if any, research environment effects do you expect there to have been? In other words, if this is taken out of the real world, would it have the same adherence and result?
Yeah, Arnold, that's a great question, and we tried as hard as we could to minimize kind of the academia research team effect, but no doubt, there's some of that there. And the way we did that is that the research team trained the RDs and CDEs, and then we tried to step as far back as we could from the work that they did and the community health workers did. The RDs and the CDEs trained the community health workers, and the RDs at this diabetes care center were hospital employees, not medical school employees. They were typical. I've been around to a few diabetes education programs. They were kind of typical of the CDEs that you find at community-based diabetes education programs. And so we would like to think that this is reasonably replicable. To test that, we got a little bit of money from the CDC and the North Carolina State Health Department. We're actually doing a next phase of a dissemination project in North Carolina now, where we're working with 5 public health departments, safety net clinics, where they have diabetes education programs and CDEs. And we've trained those CDEs. We brought them to Winston-Salem. We trained them on site, and then we sent them out. And the only connection they have with us at this point is telephone. And they are running the program in their own sites. It's very early, don't have much information on how that's going at this point, other than some of the process data that we have. But we hope to have information on whether we can take the next step and disseminate this a little bit more broadly to provide more evidence on exactly what you're asking about. Yes, thanks. Great question. So we are, as I mentioned, we're working with 5 local public health departments scattered across the state of North Carolina to test whether we can effectively disseminate this further from the academic center. We've had discussions with folks at the CDC about this particular model for translating the DPP. They are, I would say, they've been favorable in their response to what we're doing. The reality is that our work came out about a year after some work on a YMCA-based model that they'd already made some strong commitments to. And so, we have a little bit of an uphill, it's actually kind of interesting, we have a little bit of an uphill battle at CDC to get the same, I think, support for our approach to translation of the DPP as they have support for the YMCA model. And they're supporting training centers that really kind of implement the YMCA model because that came out about a year earlier than ours. And they had pretty good results, too. So I think the answer there is there need to be more than one channel for implementing the DPP. In our experience, there are some people who would prefer not to go to the YMCA for that sort of intervention. You may have seen that as well. But I think both models are effective, and they probably reach different parts of the population in need, and so we need training centers that will help deliver both kinds of strategies.